بسم الله الرحمن الرحيم. I'm Dr. Amr Mahmoud Salama, Assistant Lecturer in Internal Medicine Department. I'm going today to discuss with you how to take history taking for the fourth grade medical students. First of all, to start with, history taking is a form of art. Any art needs practicing and a good talent, and this talent can be improved by practicing more and more to become professional in history taking. Actually, history taking is the most important step in the clinical assessment of any patient. And we usually say a good physician is a good historian. In order to come up with a good diagnosis, you need to take a proper history, at least to come up at the end of the history with a diagnosis, or at least a differential diagnosis that need to be assessed later on by clinical examination and investigations. So history, as we have said, is the most important aspect of the medical examination. In order to do a good and effective history taking, you need to focus an attention to the systems or the system or the systems affected. So at the end of the history, you at least decide which system of the patient is affected, and later on proceed with the examination or the investigation needed for that system. It also gives us a better judgment of the severity and progression of the case, and many of the diagnoses can be diagnosed only by history taking, and a good physician can reach up to 80% of the diagnoses from the history. Many conditions such as epilepsy, migraine, and renal colics can be only diagnosed by history. As we have said, the history taking is a form of art. It's an art of communication between the patient and the doctor, and a good doctor should establish a good doctor-patient relationship through the history taking. The patient should be put at ease, and we should encourage him to talk freely and make it clear that the patient has the whole of your attention. You should pay a great attention to the patient complaint and the patient history. Common things toward good communication should be applied with every patient, such as greeting the patient and treating the patient with respect and calling them by their names. All these are important communication skills that need to be applied during history taking. We should not show any signs of anger or shocking during listening to the history taking of the patient. Patient must be allowed to tell their story in their own words and in their own ways, and you should listen with a great attention to these problems and their complaints. When the patient telling his history, always watch his body language, because sometimes when the patient touch a certain point or a certain problem, they show certain facial expressions or certain body languages that will help you to detect the magnitude or expect the magnitude of this problem. You should always be a good listener. Medical history taking can be divided into several categories. First of all, we should know the personal data, as we'll discuss later on, followed by the chief complaint of the patient. Then we should discuss the history of the present illness, followed by the past medical history and the drug history. And also we should pay attention to the social and family history of the patient. To start with, first of all, the personal data. Personal data includes the patient name. This is important to establish a good communication and to be familiar with the patient, and to gain the patient confidence and to call the patient by their names. The age of the patient is important because certain diseases are common in certain age categories, such as infectious fever and congenital anomalies are more common in childhood, while atherosclerosis is more common in old age. Sex is also important, as many diseases are related to the sex, such as hemophilia, which is which usually occurs in male, and certain diseases are more common in special sex, such as rheumatoid arthritis, many autoimmune diseases, systemic lupus, thyroid diseases are more common in females. Occupation is also important because certain works expose the patient to certain hazards that may make the patient susceptible to certain diseases such as infections or occupational health hazards such as occupational lung diseases and pneumoconiosis. It's also important to know the occupation of the patient because the disease of the patient himself may affect his occupation. For example, if you have a patient coming having hemiplegia, for example, and this patient is a leper or a manual worker, this will greatly affect his job. Residence of the patient is important, where the patient was born and where he is living now. As certain diseases are more common in certain places, such as schistosomiasis, which is more common in the countryside and rural areas of Egypt. Habits such as smoking and alcohol should be asked, and also you should ask the patient, especially if he is a smoker, about addiction, whether tablets, injection, whatever the type of addiction for this patient. The marital status of the patient and the number of children is important to gain an idea about the fertility, especially if the complaint or the disease the patient suffering from can affect the fertility. Menstrual history can be part of the personal data or can be as a separate entity called the gynecological or female history or feminine history. So this female or feminine history includes the menstrual history. You should ask about the age of menarche and the age of the menopause if you are dealing with an elderly woman. Also, you should ask about the last menstrual period, whether the periods are regular or not, and the time, the duration of the period, and the amount of bleeding. You should also ask the female about lactation and about the use of any method of contraception or any contraceptive pills, because many females don't mention the contraception or pills or the contraceptive methods as a part of the drugs or during drug history. So you should specifically ask about contraception. Also, you can ask in this female part of the history or gynecological history about the previous pregnancies and abortions, and how was these pregnancies, whether they were complete pregnancies or terminated by miscarriage or abortion or complicated by any form of complication that may happen during pregnancy. So we can also, to simplify, we can summarize this female history in 3 P's, which are the periods, pregnancies, and abortions, and the pills or contraceptive methods. So that's the personal history. We are going to move to the chief complaint of the patient. The chief complaint is the complaint that makes the patient seek medical advice and go to the doctor. So this complaint should be in the patient's own words. So you should take the symptoms the patient describing as it is without translating them into medical terms, and we should try to define the main complaint of the patient and its duration. We should arrange these complaints in a chronological order, which means the oldest first, followed by the most recent complaint. We should, as we have said, we should not use any medical terms, we should describe the patients in their, we should describe the complaints in the patient own words. For example, abdominal distension should be said as an abdominal distension, not translated into ascites. You can confirm that whether it is ascites or not later on by examination or by investigation, but in the history section or the complaint you should say it's abdominal distension. Also, swelling of the both lower limbs should be said as it is, swelling of both lower limbs, and not as edema. unless later on after confirmation by examination that the patient has lower limb edema. After taking the complaints of the patients, we should go on to the history of the present illness, which is analysis of the complaint. We should go in deep in these complaints to know more information about these complaints. This history of present illness will help us to put a certain differential diagnosis for the complaint of the patient. For example, if the patient is complaining from chest pain, there are many causes, many causes for chest pain, but the end of the history, you should come up by at least one or two differential diagnoses that the chest pain of this patient is either due to this or this, and then I need to do an examination or proceed with certain investigation to specify or to confirm the diagnosis. So we should ask the patient about the details of the complaint and about the story of the patient complaints. In the present history, we should ask about the mode of onset of the patient complaint. For each complaint, if the patient is coming complaining of 1 or 2 or whatever the number of the complaint, for each complaint you should ask about the mode of onset and the course, the duration of the complaint, aggravating factors and relieving factors, negative data for associated symptoms. For example, if the patient is complaining, as we have said, from chest pain, so the patient is complaining of one of the cardiorespiratory symptoms, as you will be taught later on. So chest pain is one of the cardiorespiratory symptoms. You should ask the patient about all the rest of the cardiorespiratory symptoms and mention if they are positive or negative. If they are positive, they should be complaints as well. For example, if the patient is coming complaining of chest pain, and then you ask the patient whether he has dyspnea or not, and he replied, yes, I have dyspnea. So you should go back and put dyspnea as one of the complaints of these patients. But if he said, no, I don't have dyspnea, so in this case, you should mention that the patient does not have dyspnea. It's an important negative data to be mentioned. So negative data should be for the associated symptoms, which are the symptoms of the same system of the original complaint of the patient. And also you should review other systems. There may be other complaints or other systems that are closely related to the complaint the patient telling you. For example, if the patient is coming complaining of palpitation, which is also one of the cardiorespiratory symptoms, this palpitation may be due to anemia or maybe due to thyrotoxicosis. So these are other systems outside the cardiorespiratory system, but it's important to ask about these systems because they are closely related to the patient complaint. You can also ask about the previous investigations or the related investigations if the patient has done any investigations, and also the related treatment, whether medical or surgical, for this complaint. These are the main items that should be asked to all the complaints that the patient telling you. Of course, with each symptom, you are going to study more details about additional items that can be added to these 8 items. For example, if the patient is complaining from pain, you can add to these items the type of the pain, the severity, the location, the site of referral. If the patient is complaining of vomiting, you can ask about the amount of the vomiters, the content. There are certain items that can be added to every complaint that is specific for that complaint, but these 8 items are common between all the complaints and should be asked to all patients. The additional items will be discussed in details when we discuss the symptomatology. If we are asking about the patient onset, so about the onset of the complaint, the onset can be sudden, which means that the complaint started in seconds or minutes, or acute, hours to days, like infections, or subacute, which is a more insidious onset, which takes 1 to 2 weeks, like chronic infections, or it may be a chronic or gradual complaint of gradual onset that takes months or years, like malignant diseases. The course can be progressive, which means it is deteriorating all the time, like the malignant or degenerative diseases, or it can be regressive, which is improving. It's self-limited, like self-limited conditions such as common cold, or that has responded to a treatment like acute infection or vascular accidents after receiving form of anticoagulation or thrombolytic therapy, then the condition may improve. The course of the patient complaint may be stationary, which means it is stable, not increasing or decreasing in severity, or it may be paroxysmal, like bronchial asthma, or fluctuating, which the patient goes into remissions and relapses, like chronic inflammation and some autoimmune diseases. Negative data, as we have said, it's important to be mentioned at the end of the present history that the patient does not have this and this and that. For the other complaints you have asked the patient about, review of the other systems, as we have said, if they are related to the patient complaint. Then after finishing the present history, you can move to the past history of the patient. It's the history of the previous illnesses. It may be medical or surgical. If the patient has a rheumatic fever in the past, this may suggest that now the patient is coming with rheumatic heart disease, or if the patient is having parasitic infection or schistosomiasis in the past, may suggest that, or may give you a clue to the bleeding, esophageal variceal bleeding or ascites. It may be due to schistosomiasis. Also trauma and surgical history, as we have said, history of previous hospitalization and blood transfusions, and history of previous pregnancies in females, and history of travel abroad, especially if you are suspecting infectious diseases or a disease that is specific to certain area or certain part of the world or part of the country. You can ask about travel history. Drug history and allergy. So it's important to know that drug history, it's not drug listing. It's not like to say that the patient is taking this and this and that only. It should be not only the list of the drug, it should be the details of the drug that the patient is taking, the name, the dosage, the frequency, and for how long has the patient taken this medication. And also you should know about the adverse effects of the drug, is the patient compliant on the drug or not, and why he is not compliant. If he is not, the patient may not be compliant on the drug because of a side effect or because of a financial problem that the patient cannot afford the price of the drug. So it's important to know the cause of the patient being not compliant. A history of allergic reaction to a certain medication or a class of the medication. It's very important to know this because this will affect your prescription later on. Herbal medicine and traditional medicines can be part of the drug history. Social history is important to be discussed with the patient. After gaining the patient confidence through the previous discussion, you can go into a more deep, maybe private part of the history about the social condition of the patient, the exact nature of his or her occupation. As we have said, the occupation may be affected by the patient disease, or the occupation may be a cause for the patient disease. Also, the domestic and the marital status of the patient, the social standards, his home and his surroundings, and the financial status and the source of income for this patient, because especially for elderly patient, because this may affect your prescription. So if if you know that the patient, that your patient cannot afford an expensive medication, so you should prescribe for him a suitable medication that the patient can afford and will be able to buy and be compliant on this medication. Family history is important because certain diseases run in families either due to environmental causes or due to hereditary factors. The family history, certain families may have certain disease because they are all living in the same area. For example, families living in rural areas, they all may have schistosomiasis, or because of the hereditary reasons, certain diseases can run in families because of genetic disorders or hereditary causes. Also, history of consanguinity is important because this increases the incidence of certain diseases. As we have said, genetic diseases may run in families such as sickle cell anemia and cystic fibrosis, familial diseases such as type 2 diabetes and breast cancer. Certain psychiatric disorders, hereditary, can affect patients' psychosocial environment, and certain toxic diseases like lead poisoning or infectious disease like influenza or bilharziasis may run in families. So by this we come to the end of the history taking, and by the end of this history you should be able to come up with at least a certain differential diagnosis. You may end up by having the probable diagnosis of the patient, or at least you should have a certain differential in your mind, and later on when you proceed with the clinical examination or the investigation, your aim is to prove or to exclude any of these differential. Thank you.